Thank you everyone so much for joining us today. Today we have the amazing Carmen here to talk about procedural support, especially in the ED department. So, Carmen, I am not a child life specialist, but I've learned so much over the years, so I'm gonna hand it over to you.
Awesome. Thank you. Um, you'll have to forgive me if you see me kind of bouncing. It's because I'm trying to put my baby to sleep, and she, of course, just did not want to nap before this started. So here we are, just kind of winging it. Okay, so yes, thank you, Sunny, for the introduction. Like I mentioned, or like she mentioned, my name is Carmen, and I'm a certified child life specialist. My presentation will be on procedural support and specifically in the emergency department. Throughout this presentation, I'll refer to the emergency department as the ED, just so you guys know what I'm saying. So I've been a certified child life specialist for almost 10 years. I currently work at Stanford Medicine Children's Health in Palo Alto. The hospital is also formerly known as Lucille Packard Children's Hospital. And for the past, I've been there for the past 8 years, and I'm currently a child life specialist in the PEDS ED there. In my squad, we have three child life specialists in the emergency department. So this webinar, I'll go over prioritization and what that looks like specifically in the ED, what my goals are as a child life specialist when I'm helping create coping plans and supporting the patient during the procedure, what that preparation process looks like. And then we'll go over an example of just all those pieces put together. And then I'll have time for any questions and answers at the end. So for prioritization, it looks different depending on if you're an inpatient area versus an outpatient area. In inpatient units, usually the procedures are scheduled, so you kind of know ahead of time or a day before or even a few days before what your week or your day will look like. And it's a little bit easier to kind of plan ahead. And then depending on what outpatient area you're in, some of those procedures can be scheduled and you can um, still have the time to kind of plan in the morning what the rest of your day will look like. But in the ED, the procedures are typically ordered. And so what that means is that procedures are placed based off of the plan of care after the physician meets with the patient and their family. So in the ED, you kind of don't really know what your day is going to look like. It can be a day where there's just heavy procedures, every patient is getting something done, or it can be a very light day where there's just not a lot of procedures. And so in the ED, the way we prioritize or at least try to get ahead is somewhat anticipating procedures based off of chief complaints. So, for example, if a patient checks in for abdominal pain, my mind is already working, my gears are already grinding, and I'm gonna start thinking about what the physician will possibly order to figure out why the patient is having abdominal pain. So in that case, it could be a blood test, it could be an ultrasound. So I'm already going to mark on my senses to prioritize these patients that I'm likely going to meet them and introduce myself and introduce services. And then I am always checking my Epic board or census board if the hospital doesn't use Epic. And I'm always refreshing those order sets to see if anything new has popped up. I'm looking for keywords basically like an IV order set, CBC, anything that's related to blood, or if it's like a breathing treatment, I'm looking for those. Um, and then I'll also round with a bedside nurse or the physician just to clarify if I have any questions about the order set or if I want to see what time or what their time frame is going to be to complete the procedure. This is especially helpful if I have two procedures that are going to occur around the same time. I like to just check in with the person that will be doing the procedure to see which patient I'm going to prioritize first, and then which patient I'm going to see after that. Um, at the same time, I'm considering the patient's age, the patient's development, the invasiveness of the procedure, if it's their first time undergoing this procedure, if there were any prior negative experiences, the timing of procedure, like I had mentioned, and the stress vulnerability. So there have been times where I have two IVs that have to happen at the same time. Unfortunately, in the ED, sometimes there is no leeway as far as waiting for things to happen. And so if two IVs have to happen in the same time and I'm only one person, I obviously can't be in both procedures at the same time. I will consider this last bullet point, the age of the patient. Is there a caregiver that can possibly take over to do the support? Or if I prepared the patient and they seem like they will cope fine, as long as they have their distraction and somebody else does the distraction, and I'll go over to the other patient who may not be able to cope as well independently. So my goals when I am creating this coping plan and providing procedural support is to provide accurate and complete information to the patient and their families, create individualized plans tailored to each patient, support the patient and family during the procedure, and then debrief afterwards. So uh, I'll kind of go over what these key points kind of look like in more detail later. But again, we never, as child life specialists, want to minimize what will happen. We want to ensure that the patient is or will be fully aware of what's going to happen because this is kind of how we help them create positive coping skills with procedures that are invasive or can be stressful. We also want to minimize any trauma that they might experience with these procedures. Um, and so, with creating individualized plans, every plan is usually different. It's always dependent on the patient, if they are on the spectrum, or if they are information seeking, or if they do better with not too much information. So, usually, coping plans are really different throughout each patient. So this is what the preparation process looks like. So of course, the child life specialist has to know what the procedure entails from start to end. That's how that's how we learn about the procedure and how we're going to prepare the patient. Um, Assessing the patient's understanding of the procedure, determining what information to share, preparing the patients, offering developmentally appropriate choices, checking for their understanding, support during the procedure, and then debriefing. So I'll break down what each of those points look like. So for learning about the procedure, like I mentioned, it's important for you to know what's going to happen so you know what education to provide. Ways that you can better learn a procedure is to observe. I usually will tell my interns to observe as many procedures as they can and to observe that same procedure as many times as you can. Just because you never know if something different comes up the next time you watch the same procedure. There could be something that's meaningful or something that's valuable that you can gather through that. If Other than observing the procedure, you can also talk with another child life specialist about their experience or expertise with that procedure, what has been helpful in the past, what may not be as helpful, and also talking with the nurse and the physician or any other healthcare workers that may be performing the procedure. If I'm doing a laceration repair with a physician, I typically like to touch base with the physician and learn what their style is, just because even though there is a way to repair or suture a laceration, there are, physicians who kind of have their own style. And so I like to see what they're going to be executing so I can better prepare the patient for that. And if there wasn't an opportunity to observe the procedure, or you're feeling like I've spoken about this procedure, but I just need a visual, of course, you can always YouTube what the procedure might look like, Googling, researching that procedure even further. After you have learned about the procedure and you're feeling comfortable with educating the patient and getting the patient ready for the procedure, you of course want to introduce yourself, your role, and your purpose in the room. You also want to identify who's in the room with the patient, if there are any caregivers that might be beneficial to the coping plan, or if there are any siblings who may need a distraction during the procedure, or if it would be best for this sibling to step out or wait outside with an activity in hand. And then assessing the patient's understanding. Does the patient know why they are in the hospital, or in this case, in the emergency department? And if they know what is going to happen next. Sometimes patients are already aware of what's going to happen next because they overhear the parent speaking with the physician. And other times they are just so distracted and they just didn't hear anything that was said. And so part of being a child life specialist is informing the patient of what will happen next. So as I'm informing the patient, I'm determining what information to share. And this really comes as you are telling the patient what's going to happen and seeing what their initial reaction is going to be. Um, and then finding out if it's the patient's first time, or if the patient has experienced this specific procedure before or something similar. So in the emergency department, we have come across patients who did need to do an initial blood test at either another outside hospital or another clinic. So when I do introduce or talk about that they have to do a blood test or get an IV, a lot of times they kind of already know what that entails. Um, and based off of the reaction, you kind of go from there whether or not you're going to continue with this information, or if it's best to kind of take a step back and kind of see where we're going to go with creating this coping plan. As I'm preparing the patient, I'm continually assessing their understanding and their anxiety levels, whether their anxiety levels are increasing the more I talk about this, or if it seems like their anxiety is decreasing, or they're showing better comprehension as I continue. You want to keep in mind that information should only be related to what the patient will experience, because too much information could cause confusion or distress. So with this point, if the patient is going to undergo a sedation where they're basically going to be asleep for the invasive part, or the most painful part, or the most uncomfortable part, I don't really talk about what that is going to look like, because they will not consciously experience those things while they're sedated. I only talk about what they will experience while they're awake. So I use developmentally appropriate language based off of their age. I'll explain the sequence, other than providing the educational piece of the procedure, I'll explain the sequence of events, what's going to happen first, second, third, last. I'll provide any sensory information, so like a tight squeeze, if you're going to feel something cold and wet, if you will feel a pinch or maybe a hard push. I'll discuss the length of procedure, if this will be short, like about 5 minutes, or if this is something that's going to take some time. And then I use any medical equipment or visual aids that might enhance the learning experience. I'll offer choices based off of their development and their age. Some patients prefer to watch the procedure or look away. If they want to look away, I'll offer them some distraction tools. If they want to sit by themselves or sit with a caregiver, do they want to count down or just go for it? And these last few parts are really important, especially I find in the ED, just because of the time sensitiveness of the procedure. We sometimes don't have a lot of leeway to really give the patient the time to come to terms with what's going to happen. So I do like to ask my patients if they feel like they need assistance in keeping their body still, whether that's their arm for an IV placement, or if they have a lac repair, if on their leg, if they need help keeping that leg still. And I always validate that sometimes when we're nervous or scared, it's really hard to remember that we need to keep our body still when the procedure is about to happen. And so that it's always okay to ask for help in doing so. If they've done the procedure before, I like to ask if there were any positive existing behaviors that were helpful in the past, and then reinforcing those behaviors or incorporating it into the coping plan. And if they had a negative experience in the past and the previous coping plan just wasn't helpful, then my job is to try to help them find more effective behaviors or to create a more positive coping plan. And sometimes patients are just unable to decide. This can be because they are so heightened by their anxiety and their stress levels that this procedure is about to happen. And that is okay. Their body is just in like this flight or fight mode. And basically, they're not going to be able to hear anything that you are going to say. And so when this happens, I refer to the caregiver to see what they want to do, or I help decide and create a coping plan that is appropriate for their development or for their age. After I provide the educational piece and create the coping plan, I then check for the patient's understanding. And there's various ways to do this. Of course, you can ask them if they understood, and they can say yes or no. But a better way for me to accurately assess their understanding is by asking the patient to practice on their teddy bear. I want them to show me what I showed them essentially. And then also asking what their job is going to be during the procedure. Do they know that they have to stay still? Do they know that their job is to engage in the distraction video that they picked? And then my favorite way is to rehearse. So allowing the patient, allowing the patient to allow me to demonstrate the steps on them. I feel like it gives me a better understanding whether or not they are really going to keep their arms still during the IV or if they are going to flinch or move away. And I'll kind of go over what that looks like in an example that I have later. So then there's the support during the procedure. Once I've spoken to the patient and we've created the plan, we figured everything out, I will share that plan with the nurse or the physician or any other person that will be doing the procedure. I tell them any specifics, such as the patient wants a countdown, or the patient does not want a countdown, and you can just go for it. Or the patient prefers for you to not talk about the procedure as the procedure is happening. They just want to be fully engaged in that distraction. So little things like that. And then helping the patient to get into position. So I usually like to start with the patient before the nurse or the physician gets to bedside. I really feel like this kind of helps them transition into the procedure itself. So if a comfort hold by the parent is part of the plan, I start to sit up the bed. I position the parent in the right way. I help get the patient between their legs, and I guide the parent into that proper comfort hold where their arm and hand placements are going to be. And then I get that distraction ready if they want to play a iPad game or if they want to watch, Peppa Pig. I'm getting that video ready and getting them engaged in it. And then not all coping plans go the way that they're supposed to, and that happens a lot, and that is also okay. So adapting quickly if the plan deviates. Part of being a child life specialist is kind of, knowing what to do next or what to offer next. That might help in the moment. After the procedure is done, I then like to debrief or check in with my patient and see how they felt about the procedure. I like to ask if they felt that the procedure was easy, or of course, I'll know that it was hard or challenging if they are still crying about it. Um, I also like to check in with the patient to see if they liked that coping plan, or if there was anything that they would like to change about that coping plan if they were to ever have to do that procedure again. I provide any praise and validate any emotions that occurred during the procedure. So, I always like to say, like, you did so well keeping your arm still, and you did that all by yourself. Or if they were crying throughout, which crying is a normal and appropriate reaction, but they were able to keep their body still, even though they were crying. I like to point that out that even though you were crying and this was so hard for you, you kept your body still, and that was exactly what we needed to do. You are so great at doing hard things. Um, and then noting what the patient might need for future procedures. So if it was a coping plan that didn't really go out the way we had expected, I always like to put in my chart notes future considerations for this patient, what might be helpful. For example, if the patient stated that they wanted to sit by themselves, but they were not able to hold still, I'll then probably put in in my note for future consideration, patient might benefit from a comfort hold. Um, and then as I'm creating these coping plans, as I'm engaging with the patient and the caregivers, I'm keeping in mind all the child development theories that we've learned in school. I'm not going to go into too much detail with this just because that's kind of a whole other webinar and topic. But as I'm offering choices, creating plans, these are the things that I keep in mind. So for interventions, so for infants 0 to 18 months, I like to prepare the caregiver just because the patient is not at a stage where they can understand the information. Um, and so I'm really providing the education to the caregivers using adult language, of course. An example of this would be if the patient needs to have a urine catheter. Um, That's one of the primary procedures we do in the ED when we have to do a urine test and the patient is not potty trained yet. We then have to do a quick urine cath. And a lot of parents are not familiar with this procedure. They do not know what tools that entails. And so I will show them the catheter and I tell them that it's a soft a soft tool that will be inserted into the urethra. And a lot of caregivers also are not aware of the anatomy. Not a lot of parents know that for females that there's a urethra and then there's the vagina, and we're sticking the catheter into the urethra and not into the vagina. And then for males, we insert the soft tube into the penis and into the urethra to collect the urine sample. And then for this age, a lot of caregivers, they become emotional. It's very difficult to see their child, crying or in pain or even in discomfort. And so I always like to give them the option to either remain at bedside or step out. And knowing that stepping out does not mean that you've abandoned your child. It's just part of that parents' coping style and what they need to do to continue supporting their child while in the emergency room. And then some interventions that I would use here for this age is a pacifier with Sweeties. So going back to my previous slide with Freud, babies and up to 8 months, they're in that oral fixation stage. And so they find comfort in that suckling. If you're not familiar with what Sweeties is, it is a low sugar water concoction. And we use the Sweeties to encourage the baby to suck on the pacifier to keep them focused on that. Swaddling will also help. Babies like to stay nice and cozy and nice and tight, and that just brings them comfort. I like to throw in a white noise machine for some of my newborns. I'll do the heartbeat because they still find comfort in hearing their mom's heartbeat when they were in the womb. For some who are a little bit older, I'll just do the typical white noise in the background. And then for some of those older infants, a rattle can be distracting. For toddlers, 18 months to 3 years, I also will prepare the caregiver, providing that educational piece. And if they are closer to 3, depending on the the development of their cognition, I'll provide a brief verbal explanation close to procedure time. And so typically this kind of looks like when the nurse is like gathering her supplies and I'm helping the patient get ready and the caregiver into the proper position. I'll verbally say like, we're going to do a blood test. Like it's time to go and sit with mom. And we're going to use a soft straw or a special tool to do this, and you get to watch like an iPad if you want, or we can do the light up toy or the bubbles. For preschool, 3 to 5 years, I'll provide a brief explanation close to procedure time. And the reason why I do this is because I don't want them to have to think about the end or create anticipatory anxiety thinking about the invasive procedure that's about to happen. So usually they cope better when it's closer to the procedure time. We'll do some medical play if there's time, just to make sure that they were able to manipulate the items, do a visual. This is when those doctor kits really come into handy. And for the intervention, usually with this age, we will encourage caregivers to help with that comfort hold. And then I will let the patient choose what distraction they want to engage in. And usually that's like a YouTube video of like Paw Patrol or Peppa Pig. For school age, 6 to 10 years old, I'll provide the education piece prior to the procedure time. So this could be like 30 minutes before, an hour before, and I'll usually use like a medical kit visual. So these are actual medical equipment for them to manipulate, look through, ask any questions, do the demonstration of each step. And then I'll give them choices of what they want for their interventions. So some of them like to hold their caregiver's hand or they'll hold my hand. Some patients do better watching the procedure, and some patients do better engaging in a distraction. For adolescents and teens, so for adolescents 10 to 13, and for teens 13 years and up, they are pretty similar in as far as providing that education piece prior to the procedural time. Of course, my language is going to be more mature, more adult-like the older that they are, and I'll still use that medical kit or medical equipment as their visual aid. And then I still will give them choices to see what would be helpful, whether that's watching the procedure, using a stress ball, in their other hand. I have found that coaching them through the breathing techniques during the procedure has been a really popular choice. I like to use the box breathing method where you inhale for 4, hold for 4 seconds, exhale for 4 seconds, and hold for 4 seconds. A lot of teens also prefer just to engage in a conversation about anything, and that really helps them. And then, as you may already know, privacy is really important in these age groups. And so, if a patient comes in with a perineal abscess, which is like an abscess right above your butt crack, then I like to just provide the verbal preparation, what the patient will experience, what the patient will feel, and then give them the option. Do you want me to stay supporting you, or do you feel like the least amount of people is better for this situation? Especially if the patient is also of the opposite sex and they're coming in with like a testicular torsion or something with their penis. I just like to give them their privacy and their space. I'll still prepare them if they feel like that information is helpful, but I also know that staying may not always be helpful. So let's go over an example. So we'll do an IV since we are always doing a lot of those in the emergency department. So the first thing I'm going to do is introduce myself. I like to keep my intro pretty simple and more specific to the emergency department. So I'll say, my name is Carmen. I'm kind of like a teacher, and my job is to help you get ready for things you have to do in the hospital. I don't really refer to the emergency department as the emergency department because to a 7-year-old, it's just the hospital. And for a 7-year-old, they are familiar with a teacher. Hopefully, they go to school. And so I like to relate myself in that sense that I am in kind of like a teaching role. And then that my job is to help them get ready for things that the doctor needs them to do, essentially. I ask the patient why she's here. She tells me that her stomach has been hurting. So I like to use what they say as a way to tie into why we have to do what we do. So I explain that because your stomach has been hurting, we have to do a blood test to see why your stomach is hurting. And then I ask if this is something she's done before or if it's her first time. And in this case, in this example, she tells me it's her first time doing a blood test. And so I tell her the way we do a blood test is by using a plastic straw called an IV to collect her blood. I also ask her if she wants to see what this tool looks like. Most kids at this age, they're very curious, and so they do choose to see. And for some kids who have experienced blood tests in the past and have had a negative experience, they typically will decline looking. And if they do decline looking, I will still verbally tell them what is going to happen so they at least know what steps will happen. And so I wish I actually brought mine out just for this visual, but I'll show her what an IV looks like. I will emphasize that the catheter is a soft, bendy straw, and I'll encourage her to manipulate it, to bend it, bring it close to her body, to create that comfortability. Once the patient appears comfortable viewing the IV, I then move on to the sequential steps. I will sometimes, if I have a teddy bear, I'll demonstrate on the teddy bear. If the patient is looking a little apprehensive, I'll then demonstrate on the caregiver or myself. And these are the steps that I will say as a part of my IV education. Step one, the nurse will use this rubber band and place it around your arm, and you'll feel a tight squeeze. Step two, the nurse will use a sponge to clean your arm so there's no germs. The sponge feels cold and wet. Step three, the nurse will slide the straw into your blue line, and you might feel a small pinch or nothing at all. And this can be the case if we use a numbing cream for the right amount of time. Patients typically don't feel a pinch sensation. And then step four, the nurse will use tubes to collect your blood and then put a big tape over your straw to keep it safe. Step five, the tight squeeze will come off and then you're all done. As I'm telling her these steps, I'm assessing the patient for what she thinks about the information, and then provide any clarifications she has to those questions or concerns. Oftentimes, patients, oops, sorry. Oftentimes patients think the IV is a needle. And so I always emphasize that it's just a plastic straw. I don't actually really talk about the needle in my teaching, and just because that is a piece that they don't necessarily will see or experience, especially if they are distracted. The only time I do bring up the needle is if the patient specifically asks, how does the straw go into my body or into the vein? And even then, I don't really refer to the needle as a needle. I say that it's a special tool that helps the straw go into the right place. And once the straw is in the right place, the tool comes out and gets thrown away in the trash can. I have found that if I use more threatening words like needle, their anxiety tends to heighten, and sometimes it can be a little bit more challenging to bring them back to baseline or bring them back to focus on the education piece. After the patient has no questions or concerns, we then move on to the coping plan. I give her options to help enhance the procedure. Do you want to play a game? Do you want to watch a video? Do you want a countdown? And then also discussing the importance of keeping her body still, and giving her the option if she can keep her arm still by herself or if she needs someone to help her do that. I continue to check her understanding by asking her to either demonstrate on the teddy bear or allowing me to practice on her. And so my role during the procedure is, of course, to execute the coping plan that was created collaboratively by the patient, caregiver, and myself. Again, not all coping plans go the way that they're supposed to, and so it's really important that I adapt to fit those needs in that moment. And then always debriefing after the procedure. And the timing of this depends on the patient. If the patient has a negative experience, it's of course not the appropriate time to debrief right after. I'll probably give the patient like 10 to 15 minutes, wait until they return to baseline to come back in and check in on their coping. Um, and that's basically it. These are my references. And so I don't know how much time I was supposed to have, but if there are any questions, I'm happy to answer any.
Thank you, Carmen. We do have a question. And if for anyone if you have questions, please put them in the Q&A where you put it in the chat. So I'll read the first question. What positioning do you use for older infants for IV placements where blood draws? I found once they reach this age, they get more distressed when they are swaddled or laying down.
Yes. So for those like older infant age, I would say that typically in the ED, when it comes to IVs, the easiest position for them to be in, I wouldn't say the easiest, the more optimal position for them to be in for the nurse to do the IV will be the patient's back to the caregiver's chest. So the patient is facing out, and then the parent can have one leg over each leg, and then one arm over their chest and then the other arm over the patient's belly, and then also holding the other hand. Um, I usually only provide or give this comfort hold an option just because, like I said, it is most optimal for most nurses. There are some nurses, however, who are a little bit more flexible, and you kind of know who those nurses are. And those nurses, I will then leave it to those nurses to be more comfortable with maybe like a chest to chest or any other positioning, such as like in a breastfeeding position, if that patient finds comfort through nursing. But I really leave those rare options to the nurse just because I'm not the one placing the IV, and I would rather have the patient in a more optimal position for the nurse to get the IV right the first time. Hopefully, I answer that question.
Next question. What does your role look like during a trauma? Is one voice utilized?
Yes. So over at Stanford, and I can only say this specifically to Stanford, and just because I know other EDs aren't really set up like this. So for us at Stanford, we are at the head of the bed next to the physician who's running the trauma. We are in the room prior to the patient arriving, so we can help receive that patient. And the moment the patient gets on that bed, I am in that patient's ear. I am whispering to let the patient know really quickly, like, my name is Carmen. My job here is to support you while the doctor takes a look at your body. The doctor is going to use their eyes and their hands to see what's going on. They're going to ask you questions and you say yes or no. And that happens like really like in 30 seconds because the physician needs to get started on their trauma survey. The physician's voice is the only voice that is heard throughout the trauma. So then that way the trauma nurse who's documenting and taking notes can hear clearly what's happening, and also for the other nurses at bedside to do what they need to do, give meds, place an IV, whatever that they need to do. Um, my involvement verbally depends on how the patient is coping. If it seems like the patient is able to answer the questions by themselves, then I kind of just take a step back because I know that most of my role will be the debriefing part when the trauma survey is over. If the patient is more heightened and they do need someone to kind of help them return to baseline or talk them down, then that's when I am more involved verbally. Other ways that I do chime in is when the physician asks a question that the patient might not understand just because of their age. I then will help rephrase it. So a lot of times our physicians will say, like, do you have any injuries? And this is like a 4-year-old. And I'll be like, do you have any owies? And then the 4-year-old will be like, oh yeah, like this is an owie. And so sometimes in those instances, I'm just helping to re-clarify what the physician is asking.
And I
And then, oh, sorry. To add to that, if the patient is not conscious, usually we do know that ahead of time. Other times we find out as the patient is being brought into the ED. If they are not appropriate for child life services, then my services move to any siblings or caregivers that show up. And then I narrate to the caregiver what the physicians are doing. We do encourage parents to watch what is happening, especially if life-saving measures are being performed, because then this does not leave any room for question or not questions, but like when parents ask, like, did you do everything that you could have done to save my child? This allow parents to know that everything was done. They visually saw that everything was done.
Great. How do you gently enforce one voice principles with staff and family? You might have answered some of this, but
Yeah. So one voice, it is very difficult to enforce. I feel like one voice it really is dependent on the personalities that are in the room. I will say that I will emphasize the one voice if the patient or the parent has informed me that they have a sensory processing disorder or if that they are on a spectrum. I will let the nurse know and any other people helping this that it's either the parent that's going to be talking or providing the distraction and the support, or if it will primarily be me. Sometimes I'll use other subtle cues, like if the nurse or the physician is trying to engage with the patient, I'll say like, "Oh, you're so focused on the iPad video. Like, can you hear what's going on?" And it's kind of just these like little subtle cues to kind of tell everyone like, "Hey, let's just minimize the talking to the patient." Or like, mom is saying all the right things, like just keep focusing on mom's voice. And so it's hard. It's really hard to enforce the one voice. It doesn't always happen, but you kind of know when it's appropriate to really ask for that versus kind of letting it slide.
next question, how often do you provide a comfort hold when a parent cannot? Is this a standard practice for you, or do you find it in a rare occasion when you provide a comfort hold?
I have found it as a rare occasion when the parents don't want to do the comfort hold and then I do the comfort hold. I feel like parents, they kind of have they kind of want to be like protective in a way. And sometimes I don't really give them the choice. I guess when I word the comfort hold, I'll usually say, like, with this age, we usually encourage a comfort hold where the parents help. And so it's really not a yes or no. Um, Parents who know that they would not cope well in that procedure will already tell me ahead of time, like, I don't think I can do this and I need to step out. But it's pretty rare that does happen. And if it does happen, it's parents who usually have a chronic kid and their patient or their child has already done this before, and they just know as parents that they're not helpful to the patient's coping.
Next question, do you help with trauma alerts or code blues?
Yes. So if the patient is conscious, I am there with the patient. Um, if the patient is not conscious, then I will be a support system to the parent or the siblings. Before this past year, we did not have a pediatric social worker. So a lot of times my role was to help support parents. But now we do have pediatric social workers. So my role has kind of moved away from supporting the parents. And so if there are any siblings involved, I usually will have the siblings sit in a private room during those code blues or during those traumas, and helping them understand what's going on.
And then what response do you give when nurse or providers are resistant to a comfort hold?
Yeah, so that can be really challenging. Again, it's It really is dependent on the person's personality as far as like how much you want to push. I definitely do have some nurses and some physicians who are all about the wrapping in the burrito over the comfort hold. And so I just like to word it as, the mom would like to try a comfort hold. If it seems like the patient is not going to cope well with that or do well with the comfort hold, then we can definitely do the wrap. I also like when the nurse is in the room to hear the parent's response when it comes to this, especially for those nurses who prefer a wrap or a burrito blanket. I feel like when they hear it from the parents' mouths, they can't really say anything, because that's what the parents want, and we have to respect the parents' wishes first. But you kind of know who you can kind of push. I have some residents who are new to peds and they have always just done this like burrito wrap. And then so I'll kind of come in with like, like a friendly, like open teaching demeanor. And I'll just be like, hey, like, have you ever tried this out? I've seen it very successful in my experience. Like, if you don't mind trying, of course, if it doesn't, go well and the patient keeps moving, then we can definitely do the wrap. But I would love if we can do the comfort holds first. And most people, when you approach it that way, are very open to that.
Okay, next, what do you have on hand for quick activities for patients and siblings, since there's not a lot of room for multiple parts, items, and cleaning?
Yeah, so I would say in the ED, we have probably the least amount of fun resources in comparison to the other units in our hospital. And so a lot of these items are basically like one-time giveaways. So it just kind of looks like, coloring sheets, crayons, small Play-Doh tubes. We do have some like bigger toys that we do lend out for patients who do end up staying there for a long time, but we always try to get them back, especially if they are going to be admitted to the children's side. We do a lot of like sticker sheets or like paint by sticker type items. A lot of stress balls end up going. A lot of fidget toys, but a lot of times they are one-time giveaways because we don't have a lot of space to house that much resources. And a lot of times patients do like to take those items home, and so uh, yeah, it kind of helps in both ways.
Next, awesome that it sounds like Child Life, a designated spot in your trauma awesome that it sounds like Child Life, a designated spot in your trauma situations. What is your advice or suggestion to child life specialists that are working in settings that aren't as established as Stanford? What would you advise they tackle first outside of establishing rapport with staff?
Yeah. I would find who the nursing educator is, or who the sorry, my mind is blanking on this role, but the person who's in charge of the like residents or the physicians, and talk with them about how child life can be important in helping receive the patient when they first arrive. I think a lot of times for institutions that aren't familiar with child at bedside, seeing the success to that. And so, providing that education piece, any research that you can find on that, providing that as like concrete information, but also asking them like, hey, like, can we try it out on like a soft trauma, like a patient who like maybe fell and then is categorized as a trauma, but is like 100% okay. Like, can we start there? And once they see that, like you are successful and in supporting the patient and being there, then they might be more open to you helping in more intense traumas or more advanced traumas. I would say that I got lucky because the child life specialist before me and my current group worked really hard to instill child life services. And it's to the point where even the adult side, our emergency departments are separate now from peds and adult. Our adult side will call us if any pediatric patients accidentally show up there, and they are also really receptive in seeing us help, and they are really receptive in us being there at bedside, at the head of the bed, supporting the patient. I think it also really helps to show that you're not going to be in the way. Um, and you also have to be flexible that not all the child life stuff that you learned in school will be applicable. So, like, we're not going to have time for a numbing cream. We're not going to have time for a numbing spray to do that IV. That IV needs to be placed. And basically, the only support you're going to be able to provide is a verbal support. We're not going to have time to hold up the iPad. We're not going to have time to have parent come to bedside. The parents maybe aren't even there. So, there's just going to be compromises, and you kind of need to show that you're on the nurses and the physicians team, that you're trying to help them versus be more an inconvenient, if that makes sense.
Next question. How do you prioritize griefs when you are when you are in the ER?
Yeah. So whenever there's sorry, you said grief, like as in bereavement.
Yes.
Yeah. So whenever there is a bereavement, that takes precedent, and everyone in the emergency room knows that. Our nurses and our doctors are aware that we are the ones to provide that support to either parents, but especially siblings. And so we just inform the staff like, hey, I have a bereavement. Um, Kind of know that I will need to focus on that until I'm done. And if that includes like handprints or informing siblings about their deceased sibling, whether that's giving the family the resources of grief, of what to look for in the next coming days and weeks, and how to help siblings cope. And that can take a couple hours. And so, in that sense, unfortunately, I am not available to support other patients through the procedures that they have to go to. Of course, if there is a chance for me to kind of step away, like I'm giving that family a break, and I'm available to do a procedure, then I'll do that. But otherwise, whenever there's a bereavement, I'm kind of just like reserved for that family.
Great. Next one. Do you ever have to jump in and out between patients? How do you prioritize when there's multiple patients needing your services at once?
Yeah. So this is when I really ask like, hey, like I know this patient has an IV ordered. I have a lac repair that's about to happen. Like, what is your time frame looking like? Is this IV like needed immediately, or can we wait? I really like to communicate what is basically on my plate and what is on my agenda. I want to show that I want to be there for both of these patients. And so if it is possible, if the blood work can wait after my lac repair, or if the lac repair can start after I'm done with this IV, just really communicating and kind of finding out if there is flexibility to the start time. And if so, like, I'm going to do this, it's going to take this amount of time, and then I'm going to come to you. Just really coming up with like a game plan on how to kind of execute. There are times where, like, if I'm supporting a lac repair and I know like, oh, this patient is going to have an IV soon. If the patient is coping well with the lac repair, they're already in the middle of like their fifth suture and they're engaged on the iPad. There's no like talking that needs to be done. Then I can always ask the family like, hey, mom, like, do you mind just holding the iPad? I need to go check on one of my other patients, but I'll be back. And that has happened sometimes, and that has also worked well. And other times, like, it's just not possible. And that's when you really have to use your prioritization skills and see like, hey, like which one would benefit from my services more than the other. And realistically, you're not going to be able to provide child life services for every patient. Um, and you kind of just have to be able to cope with that reality that is, it's just, we're not going to be able to meet every patient, unfortunately.
Okay, next one. Love this. I would love to share with my team later. We just started a program in ED a year ago. What is your staffing like?
So for us, there are three child life specialists in our PTD. We used to have four, but we've had some changes happen. And so now we have three. My schedule is a reduced schedule. So I work 4 days 1 week, and then I work 3 days 1 week, and those are 8-hour shifts. I start at 2:30 and I go up until 11 p.m. And then my two counterparts, one works Sunday through Wednesday from 12:30 to 11, whatever a 10-hour shift is. And then my other coworker works from Wednesday through Saturday in the same time frame. So Monday through Friday, we typically have two child life specialists, and that really helps with our census. And that really helps kind of, if I'm not able to be there for one of my patients, my counterpart can help jump in. And then on the weekend, we only just have one person covering.
Next question. What are your few must include steps, things to cover for preparation when you don't have time to go in prior to the procedure for a full prep and teach back?
Yeah, that happens a lot. So I usually like what I'll tell my intern, like if you could pick three things from your prep, what would you say? And those are kind of like the three things that I will kind of say, and then we're up and going. So like for an IV, a lot of times like we just have to do it. And so I will just quickly say like we have to do a blood test. We're going to use an IV. You're going to feel a little pinch. And then like let's kind of get ready. And sometimes that does happen, especially like in a trauma, or if like all of a sudden there was an IV order and I had no time to prepare the patient and we do need the blood now. I'm kind of just preparing the patient as the nurse is getting set up. And sometimes those experiences go a little wonky, but sometimes they kind of go pretty well. Um, as I'm like going, like free flowing, like the explanation or the education piece. Um, so yeah, hopefully I answered that question. Sorry, I lost my train of thought as I was saying that.
Next question. Have you ever supported a teenager experiencing a miscarriage in the ED? If so, what kind of interventions or resources did you use?
Yeah. So in our AD, we do have our social workers, and so they primarily do provide that support to patients who have experienced a miscarriage. Um, I try not to overstep my social workers' toes. They are, I would say, in my professional experience, they are the experts in that role, but they also understand my role and they kind of know whether or not I need to be involved or if it's just best to just have the social worker involved. They are equipped with the right resources, and the ours are our social workers are also licensed therapists, and so they can also kind of provide that other piece to that support. Um, I have not yet to provide specific to support to any like teenagers who've had miscarriages in the ED, just because our pediatric social workers are already so good with that.
And then we have a few more questions. How do you work with patients with autism during a trauma survey? Do you guide the parents to speak to their child?
Yeah, so if a patient arises as trauma and is autistic, I will kind of look to see how is the patient responding. Is the patient engaging with the physician who's running the trauma survey? Is this patient nonverbal? Is this patient giving different cues? And if the parent is there, I will quickly ask the parent, is your child nonverbal? Please tell me about more about his or her development. And if that is the case, I will chime in during the trauma survey to just note the patient is nonverbal, may not be able to respond to questions. Um, and that is okay. If the parent is not there to confirm the patient's development, um, they kind of do look at us to kind of see like what are we assessing, and we just tell the physician our assessments. They can be a little bit harder to support, just because you don't know exactly what their comfort or their needs are, but we have to get through this trauma survey. So you kind of just swing it and try to help the best you can. And then again, there's always that debriefing factor um, after everything is done.
Okay. And then how long would you say it took for you to build rapport with your ED staff, and what did you do to help foster those relationships?
I would say I am pretty slow to warm. Like, once you get to know me, I'm pretty social. I am very friendly and, but I would say like I'm pretty slow to warm and shy in the beginning when I'm first meeting like a group of people who are already friends with each other. It's just so intimidating. I also am not like super talkative. And so I do have to force myself to come outside of my comfort zone and introduce myself, get involved, get myself to bedside sometimes before the staff does, to really like implement myself. But I have found, especially in the ED, that we all just end up being trauma bonded, unfortunately, in the worst ways. And then that's kind of how you start like building your connection when you start debriefing with each other. We do have a lot of travel nurses, and so whenever there's like a procedure that like maybe didn't go well, I kind of like to point that out, like, man, that IV was really hard. Like, I wish it had gone better. And you kind of get a better feel of like, what that nurse's personality is like or what that nurse's preference is. I also, with new nurses, like to introduce myself. And if like an IV, sorry, I know I'm using like this IV as like my primary example, but it's just the easiest thing to refer to. Um, I like to ask the nurse what their preference is in placing IVs, just because everyone has their own style. And I want to show the nurse that I am also on their side, to help execute this plan, and try to help her get it the first time. And then other than like talking about work, kind of like asking them like, oh, like what'd you do over the weekend? Like, something light just to kind of get the conversation started and see where you can connect in multiple ways. But I would say like, yeah, I am pretty close with a lot of my ED staff. Um, I also am very comfortable talking to doctors. I think that is like a confidence that has grown over time and definitely not something I had as a beginning child life specialist. I think when you start to build your experience, you kind of start to build your confidence in talking to other healthcare professionals, and you can kind of like chime in and like, oh, well, in my professional experience, this is what I have found helpful. And I feel like a lot of people really respect that and res he are more willing to hear what you have to say when you approach a conversation that way.
Awesome. I think those are all of our questions.
Great.
Shared so much information and we've got so many good questions from everyone. Man, tough job, I will say, being a child life specialist in the ED department. I'm sure you've seen a lot of crazy things and supported a lot of children. So
Yeah.
thank you for what you do. Let's
Of
see.
course.
And then, yeah, for everyone who attended live, you will definitely be able to earn some PDUs for this. I will be sending out an email with directions, so please be on the lookout for that email. Thank you so much, Carmen. Hopefully you
Thank
get your baby
you.
to sleep by now.
Oh, yeah, she's been sleeping this whole time, which has been great.
Awesome, awesome. Well, thank you guys, and hopefully you guys have a great rest of 2025. Bye.
Bye.